Hello, everyone. Welcome to our very first MSI Winter Wellness webinar. We are all in for a treat. I'm Dr. Roch Herold, and we're focused on a topic that impacts so many people that are just suffering silently with it, and we're going to be talking about neuropathy. And I want to say at least 1 in 6 people above the age of 65 are suffering with it, and so many people don't really know what to do. They have so many questions, so that's why this had to be one of the first topics that we dived into on our first Winter Wellness webinar. I'm thrilled to be joined by the wonderful, incomparable Dr. Allison Dondelay. How are you, ma'am?
Doing well, how are you?
All right, awesome. So she is a very well-respected podiatrist in the same town that we work in, and I just had to have her on because patients speak so highly of her. Dr. Dondelay and I are going to be discussing the 5 warning signs of neuropathy in the feet. She's also going to get into more of the biomechanics and more about other things that we should be looking out for as well. But our mission at MSI is very simple. What we want to do is we want to offer natural, high quality pain relief, but we also use state-of-the-art techniques. We use state-of-the-art modalities so that we can get patients better as quickly as possible so they can do the things that they love to do. And I'm sure you do the same things over there.
Yes.
At the lower extremity.
Yep.
Right? Harvard
Lower Extremity Specialist.
Perfect. So today it's really going to be educational. We're not giving out health advice, but it's really just more educational. And we really want to help people just avoid surgery if they can. We want them to, live long-lasting lives and, free from pain. So I would say let's dive in. You ready?
I'm ready.
All right, let's do it. So if there's so much to talk about when you're talking about neuropathy. So the way I thought about dividing this conversation is within those 5 warning signs, because these are things that so many patients, when we're talking to on a day-to-day basis, they'll talk about it in casual conversation when you're taking a history. Oh yeah, I have this. Oh, how long have you had it? 5 years. And you're just that's actually pretty serious. So I'm gonna divide it into the 5 symptoms or warning signs, and then we'll go from there. So first I wanna talk about numbness and reduced sensation, right? So with numbness and reduced sensation, when a patient tells you, okay, my feet feel like they're padded, or I can't feel the floor, what patterns are you looking for clinically, and what is that telling you? When they can't feel something or their feet is just numb all the time.
Yeah, so those type of sensory systems are usually the things that I see first. Patients are coming in, they're complaining about that. And they even will sometimes describe them as relatively mild. They're like, oh, well, it's just a little bit off, or it just doesn't feel quite the same here that it does everywhere else. Mm-hmm. And so they sometimes I almost have to pull it out of them. A lot of them assume it's going to resolve on its own. They're like, I just figured it'll go away. So most of them have had these symptoms for at least 3 to 6 months before they even come in remotely seeking care, or just bringing it up. So yeah, those are usually, it's those little things like that. That padded feeling is one of the most common things that I have patients
and I mean, I've had patients where, and of course I think it's great because I think a lot of times some people will wait to see an integrative clinic such as ours, and we'll have patients where they've had issues for over a year, sometimes 2 years, and they've been dealing with it. And they've been to this doctor, that doctor, and sometimes other clinicians kind of fall into the trap of kind of writing it off with them as well. So we like to take it serious. And what are some of the everyday risks that show up when that protective sensation is down? Because the skin, the body, of course, all of our senses are needed for a reason. And when they don't have that sensation as normal as it should, how does that lead to anything that could lead to an injury or anything like that?
Yeah, so the most common things I tend to see with people with that reduced sensation are blisters and burns.
Yeah.
They're generally happening with prolonged exposure, but because those patients can't feel this the right way, they're developing the blisters from shoes. especially if the shoes aren't fitting properly. Our feet have changed throughout our life. The sizes can change, and people don't realize that. They're like, well, I was a size 7 when I was 20, I'm a size 7 now. And that's usually not the case, especially for men.
Yeah.
So I always recommend professional shoe fittings and frequent checks of the feet with new shoes. So anytime you're purchasing new shoes, especially if you have that altered sensation, wearing them for an hour, taking them off, checking. Are there signs that there's any redness, rubbing, any blisters starting already? Wearing them in the house first before wearing them out for long periods of time, just to kind of break them in.
That's
and
awesome.
then with burns especially, that's another super common one because people don't always recognize where they could be getting burns. Like we think of a hot plate, like but baseboard heaters, space heaters, walking outside barefoot in the summertime, a warm soak at the end of the day.
Wow.
I see cases where that's happened. I had a guy lose a foot walking barefoot outside.
Wow. Wow.
He walked to the mailbox and back on the driveway. That was it. But he had bad burns on the bottom of his foot. They got infected.
His sensory didn't pick it up.
There was nothing telling him that this is not a good idea.
Wow, wow. And what are some of the underlying conditions that are usually associated with, loss of sensation? Would it,
Yeah, so in my practice, especially, the most common I see is diabetes by far. But the interesting thing is that, especially in the last couple years, I've been seeing signs of reduced sensation in patients that are pre-diabetic or don't even have that blink. And so they're coming in, they have these signs of reduced sensation, and it's a year, 2 years later, they're getting that diabetes diagnosis.
Yes.
So it's like the first warning sign for that diabetes diagnosis, and I don't think people are picking that up enough either.
And you know what? I'm so glad you said that, because as we have been, rolling out the neuropathy program, and as we've been testing and screening patients, one of the ways that we try to check for sensory is really by isolating the eyes, because what people have to realize is that so many times it's easy for us to write off, oh, well, this was bothering me, but now it's not. The reason why it's not is because our body is so smart in our divine design that if the foot is not working, the eyes are gonna work harder to pick up on the sensory. So one of the things we do is a balance test, and in that balance test, when we have a patient, I've actually been amazed at patients that I've been treating for years, and I'm thinking they're fine. I do a balance test with them, and they're falling over. Once it gets a little bit more difficult on each stage of the balance test. And what that's doing is it's taking out how the body's been compensating for so long, and it's telling the body, now you have to rely on the direct sensory information of the feet. And when that's not happening at as fast as those nerves should work, that's when you start to see it. Because the body, we don't realize it, but the body is using all that sensory information just to keep us upright when we're standing at the mall or hanging out with our kids. So I think that's very key that you said that, because there's so many patients, as they're positive for the balance test, but there's no diabetes. They have a family history of diabetes, but there's nothing that, maybe like a pre-diabetic, but nothing there that's a definitive diagnosis. So I think that's something we should kind of look into more as clinicians as well, just as like those early check signs. So now that's a good bit on the numbness and reduced sensation. So now, how about the next warning sign of neuropathy? Let's talk about tingling or burning, okay? And that's more like the pins and needles and the feet is on fire. I've been getting that a good bit. And from your chair, what does burning versus tingling often point to? Is there any hallmark findings at all in the exam that help you kind of differentiate it all from that?
Not so much, though. I mean, it's always a pretty much guarantee. If somebody comes in, there's burning, there's tingling, or there's something strange. A lot of times patients come in, they're well, it feels like there's duct tape wrapped around my foot. It feels like there's a hot poker right here. If they can characterize it in 5 or 6 words, it's almost always a nerve problem.
Yeah.
It's those weird, that they're very specific about it.
Exactly.
And so then I'm immediately starting thinking, okay, well, we know it's the nerves. What's wrong with the nerves? Is there an entrapment? Are we thinking there's maybe a neuropathy? Is there a radiculopathy?
Yeah.
Or is it a little bit of everything? Because a lot of times they do tend to happen together. So sometimes with the location, especially if it's one side versus both sides, I'm like, okay, well, Neuropathy doesn't typically happen that way. It can, but it's not as common. So I'm like, well, that can help identify, well, let's kind of look towards a radiculopathy first.
Yes.
Or an entrapment, and then kind of work our way back around.
Got it. And you know what, just for the audience, in case somebody's watching this on like YouTube or anything like that, when we talk about neuropathy, that is more a degeneration of the nerves in the distal part of the body, usually the hands and the feet. We're probably talking more about the feet because it usually shows up there. It's a longer path for the nerve to follow, so that's usually where you'll see it first. A radiculopathy is a dysfunction of the nerve root, and that's usually more closely related to the spine. So that's more of what we deal with and help people with in terms of helping them to alleviate the pressure that's on the spine, causing that nerve, because the nerves, and that's what I tell patients when I'm educating them on the brand new patient, I always tell them the nerve is way more sensitive in the spine, closest to the spine compared to all the way down here. So that's why I always want to rule that out first before we start going down there. And then you also mentioned entrapment. Just talk to them about entrapment as well, so they can kind of differentiate between.
So in my field, entrapment's typically going to be what we call tarsal tunnel syndrome, which is entrapment of the tibial nerve right around the ankle. So I always tell my patients it's carpal tunnel, but in the foot.
There you go.
So instead of having that wrist where that nerve's getting pinched, I mean, there's arteries, there's veins, there's tendons all traveling through a real tight space. The same thing can happen in the foot. And so that space is already holding all of those, and a lot of times we'll see it also happen with a deformity. So if you have a flat foot, as that foot's rolling in, that space is getting that much smaller, and so that nerve can really easily get pinched in between everything else. And so a lot of times if there's just symptoms, especially on the bottom of the foot, if there's no symptoms happening on the top of the foot, or burning around the heel and not so much to the forefoot, a lot of times I'm starting to think that there might be an entrapment of that nerve. But similarly, sometimes the sural nerve on the outside of the foot can become entrapped, and sometimes that's an injury, prior surgeries, especially knee replacement, sometimes that can happen up in there. So that's why location, again, it kind of comes back, where are you having these symptoms? Is it all 10 toes? Is it just 5 of the toes? Is it the bottom of the foot? Are you having any finger involvement?
Because if you trace it back to the spine, there's something called a dermatome, and a dermatome is like an area of skin that a particular nerve in the body controls. So that's why as clinicians, we want to know, okay, is it just the big toe, which is more of like an L4? Is it more on the lateral? Is it more of an L5? Is it the bottom of the foot? That's more like an S1. And that helps us kind of like map, so to speak. And, you know, it may not always be 100% right, but it helps us kind of at least narrow down, okay, you know what, if it's only here and it's not the whole foot, it may not be a neuropathy. It's either the beginning of a neuropathy, or perhaps there could be something coming from the spine. What if somebody wakes up with burning, if they wake up with, like, let's say burning wakes them up at night, what should they do to kind of track before their first visit? Are there things that you have patients do just to kind of, or you would suggest that you would like them to know before they come into that first visit, or just to kind of track?
Yeah, so with the burning, a lot of times, or any of the symptoms they're having, especially if they're nighttime symptoms, like what activities did you do during that day? What foods did you eat during that day? If you're diabetic, did you have any sugar spikes that were correlating or occurring right before these symptoms? What footwear did you wear during the day? Were you barefoot a lot of the time, or were you wearing a shoe? Were you wearing a shoe that is snugger than what you're typically used to wearing? Were you wearing a slipper? Because a lot of those things, sometimes we can also find correlations with that. Like the tarsal tunnel syndrome, if somebody's been barefoot all day, it's probably going to aggravate that nerve a lot more than if they were wearing a supportive sneaker.
So true.
So especially by the end of the day, if you were barefoot around the house all day, by the end of the day, you're probably going to feel that a lot more. And then especially the diabetes, those sugar spikes sometimes will correlate. I find a lot of times that the more uncontrolled the diabetes is, the more nerve symptoms they tend to have. And I mean, I liken that, I tell patients all the time, it makes a lot of sense if you think about it. I tell people, so your blood vessel is like a big tunnel.
Yes.
You got the blood cells running through their blood cells. They're about the size of a tennis ball.
Yep.
Your glucose molecules are the size of a beach ball. So they're getting there, they're gumming up the works. Your body's like, I need to get some of these through. They gotta go places, but like when there's too much, your body's gonna push that glucose out.
Yes.
And what's right next to the artery? Its best friend, the nerve.
Here it is.
They have to go together. They're
Yeah.
best friends. The artery's telling the nerve what to do. The nerve's telling the artery what to
Exactly.
do. So they run together. And when those glucose molecules come out, they latch onto that nerve and they damage it.
Wow.
Sometimes that damage can be repaired, but if you're getting a lot of those beach balls glomming on there,
Yeah.
like that, especially if the nerve is really small, like in the toes and the fingertips, that's why that damage is so much worse.
Wow.
And when they kind of think about it that way, they're like, oh, so yeah, that extra piece of cake really didn't do me any favors. I'm like, no, that was way too many beach balls.
Yes.
And then that's why it's happening in the kidneys, it's happening in the eyes, it's happening everywhere.
And that,
So-
you know what? I'm so glad you tied like the cardiovascular to that, because even when I was in school, we actually like dissected like real bodies, and one of the teachers, one of the things they told me was just remember VAN, vein, artery, and nerve, and wherever you see a vein, you're going to see an artery, and you're going to see a nerve, because they all work hand in hand, just as you said. And one of the ways that we do that, even in our screening process, is we check not just for the balance test, but we also do a thermography reading. And we're just checking the temperature. And why we're checking the temperature, we're really checking for blood flow. Because just as you said, if that blood flow is not the same here and here, and there's always like that burning or even coldness or anything like that, that's where you pick that up. And it's really kind of telling, okay, well, what's happening to the cardiovascular system, the blood vessels, and not just the blood vessels. If the blood vessels are damaged in the feet, then we know it's going to affect the nerves as well, and hence neuropathy and all of that. So, oh, that's awesome. That's awesome. So, the third symptom, the third warning sign. So we spoke about numbness and reduced sensation as a warning sign. We spoke about tingling, burning in the feet, pins and needles. That's another warning sign that you want to watch out for. The third one is more pain or hypersensitivity. So that's just where they come in and they're like, their foot is just, and it's also called allodynia, I believe, right? So that can be scary, where it's even like, and I've been dealing with these too, where they're sleeping and even the sheets are hurting them.
Yeah.
Like not like bothering them, like
No,
it's
like
painful.
painful.
Yes.
Yeah.
Like just dig into that. And
Yeah, so I love using the analogies, trying to break it down to real world situations for
Perfect.
people, because
That's what
like
I
it
do,
just
yep.
makes you understand it that much easier. So I
Yeah.
tell people, when there's something happen with our nerves, my favorite analogy for neuropathy in general is, so these nerves are damaged for whatever reason, they've gotten damaged.
yeah.
They send these garbage signals to your brain, and your brain gets that signal, and it is like, what is that trying to tell me?
Yeah.
And it's like going through a list. It's like, it's kind of like this. It's like that, and you're like, that says that my foot's on fire, and the brain's like, yes, yes, and you're like, my foot's
Yeah.
not on fire.
There's no smoke.
It's good.
Yeah.
That's not what's happening, and the brain's like, I don't know, man. That's what it's telling me.
I love that analogy.
And so like. I'm like, it's just trying to make sense of these signals it's getting.
Yeah,
So
because it's never felt it before.
Right.
Think about it. When,
It's
you know,
like,
we're in our 20s, we're in our 30s, everything's fine. But now, you know, we're getting a little older. All these new things are happening, and the body's trying to comprehend. Hey,
It's like, what's going
something.
on?
It's really, and I always tell patients, look. Pain sometimes is like one of the last things when, and that's why I don't like it when patients are like, oh well, I'll come back and get checked when the pain comes back.
Right.
Pain is like the last thing sometimes to show up. So when that pain is there, and pain is actually one of the slowest moving fibers in the body. So so when the pain is showing up, it means that, okay, it's bypassing all these other nerves between sensory and digestion, all these other nerves, it's bypassing all those, and it's saying, hey, this is more important now. So it's really knocking on the door and saying something's wrong.
Yeah.
Yeah.
That's I tell them it's like the nervous system. It's like a security system. So we're encountering things, and some things are going to set off an alarm.
Yeah.
We're touching the stove. It sets off the alarm. Our brain goes, okay, we know that's not a good thing. We're not going to do that. You kick the curb accidentally. Oh, ouch, that hurt. We shouldn't do that again.
Yeah.
When the nerves get damaged with neuropathy, radiculopathy, these entrapments, the alarm system starts going off even when there isn't danger present.
Yeah.
So just the sheet touching it is like, oh no, danger, danger. And the brain's taking that. And that's why when I explain it like that, it makes it a little easier for people.
Easier to comprehend,
It's not, it doesn't make it better. They know they're still having a ton of pain when the sheet's touching it, but they know it's also just their brain hyper-reacting to something. They're like, and so, you know, you can kind of calm yourself to I know it really hurts. I know this simple thing is, but the brain's just overreacting. Let's see if we can just calm it down a little.
Is there a way that they can do that? Like, is there a like a simple bedtime routine that you'd recommend to maybe help to reduce any kind of like nighttime pain in the feet or anything like that?
Yeah, so I find a lot of times that sensitization's much worse when there's more stress on the body. So, and that's the case with most things. The higher stress we have, the more our bodies ache. It's not just the nerves, but I'll tell people to try to get into a good bedtime routine where they're doing like some deep breathing or meditation, maybe doing some biofeedback. Meditation really helps a lot. I've had a lot of patients do apps like Headspace or Calm, and it'll lead them through some guided, so they can kind of get themselves in a good place. I'm a huge fan of magnesium.
Oh, that's perfect.
I don't know how you feel about it, but I love some magnesium. So I have almost all of my patients either take it orally or apply it.
Good.
I personally like, there's a magnesium body butter infused with lavender. So I like when you can incorporate some of those other like essential oils into it. Lavender in itself, it's just very soothing to me personally. So having that and applying it topically into the areas where it's uncomfortable.
That's awesome.
Frankincense I like a lot too, or like rosemary as an oil. They all kind of help with some of that pain modulation, calm it down. The scents are usually a little bit more soothing, and so kind of doing that, the magnesium, a little lotion if you don't want to take the, do a magnesium topically, or do a different oil, and then a little bit of meditation or deep breathing kind of right before you go to bed, and put yourself into a better state, lower some of that stress, and see if you can decrease that.
That's good. Yeah, we have a great neuropathy cream that patients like, and it's real soothing, but it's filled with magnesium in it. So no, that's a great one. So yeah, so that definitely deals with the topic of pain and hypersensitivity, and it will disrupt sleep, and it will cause anxiety and things of that nature, because that's what gets people really thinking, okay, now something's wrong. Like, if I'm not able to sleep, if something can't even touch my foot without it's screaming, I know something's wrong, and that's usually where they end up here. So one of the fourth warning signs that we want to watch out for, and this one is actually real important too, is balance changes. And with balance changes, especially as we talk about the elderly population, or even as we're going into the elderly population, this is what I told you about earlier on, when I'm just so surprised that I'm testing people and I'm not thinking that I'm gonna see any changes with balance, but I see, in fact, I saw that today, and it was somebody that even she was just amazed, no diabetes, nothing like that, but we put him in that tandem foot stance, and and she's just like, wait a minute, this is not right. And it's almost like it's hard for them to comprehend what balance red flag, what balance red flags tell you neuropathy is impacting safety, and how do you screen like a fall risk in your office and things like that?
Yeah, so a lot of times my first signs are like how they're getting out of a chair or how they're walking. And my office is right by our front door. So like if I keep my door open, I can see everybody who's coming and going. And so I'll watch, especially if it's a new patient, I'll kind of watch and see how they come in, how they sit down, and how they get up when their name's called, just to kind of get an idea of where they're at with that. And then once they get them back, I do a full panel of neurologic testing, but my favorite test specifically to kind of into balance just off that is proprioception testing.
Yes.
So for my part, proprioception is awareness of where your body is in space. So a lot of times I tell people, I'm like, you close your eyes when you're in the shower and you kind of, whoa, and that's because as soon as you took that other sensory input, like we talked about earlier, all of a sudden your body's like, oh, I have to figure out where are my feet, where is the wall, where am I in relationship to everything around me?
To the wall and to everything else.
So the easiest proprioception test I can do in the office is I just have people close their eyes, I'm grab hold of that big toe, and I start moving it up and down. I'm moving it, I stop. I'm like, where is it? Is it up towards you? Is it down towards me? And people think it's a kind of stupid test at first. They're like, okay, and then
She's wasting my time.
I'm doing it, and I stop, and they're like, and it'll take them a minute sometimes.
Exactly.
And like, yeah, and they'll guess. And sometimes they're right, sometimes they're wrong.
Yeah.
But like that one's always a red flag. I'm like, if they're failing that test, they are a fall risk, and I need to get on that. That is a big one for me. If the other tests, they don't seem to point quite as much. Like, yes, if there's decreased sensation, I'm concerned about it. But if they fail that proprioception, like I'm doing a mini balance exam, I'm sending them to PT usually. We're putting something into effect.
Yeah.
I'm not letting them leave without some kind of plan.
Something, because okay, the body just told us it doesn't know where it is.
It doesn't know where it is.
Yeah, and that's such a crucial, fundamental sensory